Well, good morning, and thank you so very much. My name is Carol Beasley, and I'm delighted to be with you. I had a little adventure, so I got to visit the lovely country of Panama yesterday, kind of a surprise visit. But it's really my pleasure to be with you today. Here's what the plan is for the next several minutes. I'm going to be talking about a sequence of topics. First, we'll start with a definition and an overview of the concept of the triple aim. And we will then talk a little bit about one of the vital aspects of this work, which is to understand population segmentation. This is population-focused work. So to understand population segments is a vital skill. I'll then touch briefly on the concept of leadership for improvement. This is work that I.H.I. has done for many years. And I think we can start to apply these leadership concepts within the context of the triple aim. And then most of my time I will be speaking of two case studies, one health system in the United States and one in the United Kingdom in England, as a way to illustrate some of the work that is going on and some of the ways that our leadership concepts are expanding and evolving. We'll finish with a few reflections, and then perhaps at the end we'll have a little bit of time for discussion. So, okay, good. So when we think of the triple aim, we really are thinking about three dimensions simultaneously, and I'd like to underline the concept of simultaneously. What makes this work so challenging is that these three dimensions, and those are the dimensions of health, the actual state of health of populations, the experience of care. So that includes both the level of quality and the subjective experience, the experience that patients have as they move through the system. Both of those are included in the concept of patient experience. And finally, controlling or reducing the per capita cost of care. They all sound fairly simple, but the fact is that they don't always pull in the same direction. It would be very easy to reduce cost of care if we didn't care about experience. We might be able to improve population health, but that might not help us with the quality of the experience. So to manage all of these things simultaneously is quite a challenge. This is the way that we look at the system or our theory for how to improve on all three dimensions. In the upper left of your screen, you'll see the little triangle that we use to represent the triple aim. And we think of this as a lens. We think of them as glasses that we look through in order to see the system in all three dimensions. In the center of the illustration, you'll see the health and healthcare system. So I would point out here that we're no longer speaking only about healthcare delivery. We're no longer speaking just of hospitals or clinics. We're also including the other services that people need to be well. So that would certainly include public health. It would include social services. It might include behavioral health or mental health services as well. We think of those things together, even though in most places they're not organized together. They reside with different organizations and different leadership. In the lower left, you'll see there is a system of measures that goes along with this, a set of options for measurement in each of the three dimensions, and I'll touch on those briefly. And then around the right are the areas where we do testing, where we're thinking about areas that, if improved, would lead to better results in all three. So I'll just say a word or two about each of those. The first is the notion that individuals and families are active participants and, in fact, often are leaders in their own health and their own health care. Most of us provide most of our care ourselves most of the time. Most of us spend little time in contact with the health delivery system, so the capacities of individuals and families are vitally important and sometimes are not fully included in our process of designing and improving systems. The second area is around primary care, so the basic services that people receive throughout their lifetimes to help them address health issues and maintain a state of health. And this, as I've suggested, we think of as a much larger domain than just doctor's offices or clinic appointments. We really think of it as including all of the things that people need to be well. I'm going to jump to the bottom of the list and work my way up. The notion of health promotion and prevention of illness turns out to be extremely important in the triple aim work, and to find those opportunities where reducing the risk of disease or reducing the progression of disease can have great benefits at a population level. Next is the notion that we have to be intentional about reducing cost. We like to think that simply improving quality will automatically lead to a reduction in cost, but often this is not the case. We really have to intentionally seek areas of excessive cost in the system and redesign them in order to get cost out. And finally, and this was an important discovery in our work, the fact in every system that we've seen is that all of the work that needs to be done to accomplish these aims is not under one entity's responsibility. Therefore, we're in the world of coalitions, we're in the world of cooperation, we're in the world of collaboration. And in order to pursue the scope of change that's needed, we need to build skills in joint leadership, in harnessing social capital to make differences that are at a much larger level of the system than we're typically used to working on. I won't go through all of these, but I put this slide in for your reference, just so that you can see there are, in fact, measures that exist. Some of these are more common in North America, some of them are more common in Europe, and I'm sure that you are either familiar with some of these measures or you will have corresponding measures that you use in your environment. But we really have tried to suggest a set of measures that would tackle the health status of a population, the experience of care, both from the quality standpoint and the subjective experience, and the total cost per person, whether that's over a year time or a month time, but per capita cost. Very easy in concept, but not always easy to measure in actuality. So we've been talking about populations, and the challenge that we face in working on populations is that not every member of the population needs the same thing. Not everyone has equally challenging or easy health issues. So this is a model of population segmentation that was described several years ago by one of our colleagues, Dr. Joanne Lin. And she and her colleagues who worked on this model were thinking about what would be a small set of broad population categories that would capture pretty much everyone, and where each category you could start to think about a coherent design of care. So she suggested 8 categories. The healthy people, many healthy people don't need very much care. Maternal and infant health, so it's a particular stage in the life of a family. Those who are very ill but are likely to become healthy, that can be cured or successfully treated. Individuals with chronic conditions who are functioning normally. So it might be someone with diabetes or someone with heart failure, but they are basically able to maintain normal function in the community, though they might be sick for a very long time. So serious disability. Relatively few people in this category, but people who do live for extended periods with physical disability. A short decline to death, so someone at the end of their life when death is occurring in a rapid process. Individuals with a series of crises or exacerbations. And then finally, frailty, and often this is the case in individuals who are older who have medical frailty, social frailty, who have a cascade of challenging issues often toward the end of life, but not a very sudden death. And you can see these are the same segments, and you'll see that the relationship between the size of the segment and the cost for that segment varies. So in the pink color, that represents healthy people, which in this study in the United States was more than 50% of the population, but they represent much less than 10% of the total cost. At the other end of the spectrum, you'll see in the top slice is people with a long dwindling course, a serious illness that proceeds through a series of extremely complicated crises. It's a very small number of individuals, but with a relatively high cost. The light green box in the middle, that's chronic illness. So many, many people in our societies have chronic illness, and it is a great deal of expense. So this gives us the ability to start to think about how would we target our designs, how would we think about where we could get the greatest benefit for the redesign work that we're doing, both in terms of the needs of people and the impact on cost. The other realization that we have been forced to address in the triple aim work is that health care is only a small determinant of health. Some estimates hold it to be about 10% of health results have something to do with health care. The other determinants are things like behavior, or genetics, or social circumstances, or environmental conditions. It's all of the circumstances that people are born, they grow, they live, they work, and they age, and eventually die, including the health system. But the health system is a relatively small level of influence on overall status of health. So hold those ideas. We're going to come back to them, and you will see how they are illustrated by the cases. But I wanted to at least provide a quick introduction to some of the thinking we have been doing about leading improvement. Now, this work was developed within the context of leading improvement inside the edges of a system. So we're going to take a look and see where we might need to stretch or expand it to deal with whole populations. But this, there's more detail than I'm going to give you, but I'm going to look at the headlines. One of the principles of improvement that we have spoken of at I.H.I. for many, many years is the notion that we need will, in other words, motivation or desire or intention to improve something. We need ideas that will be robust, that have evidence or that have an empirical experience behind them that we can use, ideas of what would make the system perform better than it does now. And we need the capacity to execute, to actually take action on the improved ideas to bring about change. For leaders, there are two other components. One is around setting the direction, setting the aim of improvement. And we talk about this as making the status quo uncomfortable, making it clear that today's situation cannot persist and will not work for very long into the future, at the same time conveying a sense of vision and possibility about an attractive future. So those of you who are leaders, I'm sure will recognize that as part of what you do. The other thing that leaders do is establish a foundation for improvement, to set up the conditions and the capacities within their organizations and their teams to make the changes that are necessary. So sometimes that means building improvement capacity or capability, the sorts of things that Pedro earlier was speaking about when he spoke about the quality and innovation centers. So that, again, is a broad framing of what leadership for improvement might look like. So now I'm going to ask you a question, because part of what this work is about is thinking and acting in new ways. So I'm going to ask you to look at this picture and guess who might have made this picture. What artist might have made this picture? Any ideas? Say. Yes, so can someone translate for me? Yes? Michelangelo. So, okay, so that's a reasonable guess, isn't it? Sometimes people might say Leonardo da Vinci, someone in a classical tradition. Okay, what about this picture? Who do you think made this picture? Picasso. Okay, well, here's the interesting thing. Picasso made both of these pictures. The first picture was made when he was early in his career. He was studying, he was learning the classical skills of an artist. He was learning from classical sources, and you can see how skilled that picture is. But as he progressed through his life, he learned to use his skills and take action in new ways. His skills didn't go away, he still had them, but he was using them to say something new about the world that he saw. So I think that is our challenge, is to take the things that we know and the skills that we have and apply them in a new way. So that's what I'm going to talk about now. Oh, that's interesting. Okay, well, I think maybe my slides were in a slightly different order, but that is fine. Actually, that's fine. So let us think about what our systems might look like or how we might see them if we were taking our knowledge and looking at it in a new way. So this picture might look a little bit different from you, but basically in North America we have health delivery organizations like hospitals and primary care clinics, specialty physicians, other kinds of services that we would think of as health. We have health plans, which are systems of insurance, ways to pay for the care. We have social services, we have public health, we have employers and school systems and community organizations of all kinds, and you could probably add some more boxes to this diagram. So often when we're thinking about improvement, we will draw a line around some part of this system and improve within the edges of the system. So for many of us that grew up in the healthcare quality improvement world and culture, we would be working in that upper left-hand corner. We would say, okay, what can we do to make the health system better than it is today? And we might think of the groups that are working on public health or social services as being in a somewhat different world. But the triple aim challenges us to redraw those lines, to think about the edges of the system in potentially a new way and a more inclusive way. So that if we're working in the triple aim, we might in fact include all of those components of the system into our frame of action and into our frame of strategy. So I'm going to introduce you now to a couple of triple aim sites. And the little dots that you see on the screen represent all of the sites that we have worked with since this work began in 2007. More than 100 organizations in 9 countries have been part of our work and have helped us to learn. And I'm going to talk about one in North America and one in England. And I'll start with the organization called Bellin Health. They are a health system in the north central part of the country in Wisconsin. They are part of, there's a lot of information about them in a book that was recently published by our Chief Executive Officer, Maureen Bizignano, and her colleague, Charles Kenny. So there's lots more information on them if you find them to be interesting. In American terms, they are a fairly typical system. They have hospitals, they have a rural hospital, they have a medical group that provides primary care, they have a group of specialists, they have a psychiatric center, an orthopedic surgery center, and a hospice program, as well as some health professions education programs. So they're quite integrated already, and all of the little dots that you see on that map are locations where they are present in northern Wisconsin, in a region of about 600,000 people. So that while they look fairly typical for an American system, they're not typical in their capacity to improve. So this is an organization with a great deal of sophistication about improving their processes and improving their results. This work, they've been with us in the Triple Aim since we began the work, and this work has really pushed them to think about how would they segment their own population. So here is their chosen way of segmenting. One of their customer groups is employers in the area. And employers in the U.S. are the organizations that pay for a great deal of health care. They provide health benefits as a condition of employment, and they purchase and pay for a great deal of care in the United States. And Bellin has a number of employers in their area that are their customers. So they started to look at what are some of the issues around health care that employers find to be challenging. And here's a list of the top ones from a research firm that is focused on human resources consulting. So poor health habits, the number one concern. Workers that might smoke or be obese or not get good activity or have a drinking or substance abuse problem. Underuse of preventive services, overuse of very high-cost services, little understanding of how to use the benefits well, no transparency about provider cost. So those are the kinds of things that are troubling to employers as they try to pay for the expenses associated with their business and they try to have a healthy and productive workforce. So what Bellin did is that they started with their own employees. It's a fairly large system. They have over 3,000 employees. And they said to themselves, if we can't do this for ourselves, then we do not have credibility when we go to the employers in our region to offer our services to them. So they started on the dimension of health with really working with their employees about their own health. And you'll see this is a group of, early on, they had 83 employees that worked on this together. Among them, they lost 525 pounds, 436 inches, so the measurements added up to a lost 525 pounds, that's, I don't know, like 5 people or something. And they substantially improved their health risk assessment. That's what HRA stands for, their health risk assessment. Bellin now performs a health risk assessment on every employee in their system, and they track that. So this was an early success. They've taken this to all of their employees, and you can see that on their measure of employee health, they have substantially improved the level of actual health of their employees. So on that dimension of the triple aim, they're definitely making progress. In addition, they have really thought about the delivery of care and the care experience. So this shows how their care is organized, and they try to direct with the lower cost options near the bottom of the triangle and the higher cost options near the top. What they have done is to try to make the lowest cost options easily available so that if someone becomes sick in the evening or on the weekend, they don't have to go to the emergency room. They can go to a 24-hour clinic that's open for them. They can call a nurse on the telephone and get help. And they have a very robust information system that makes sure that all of the information about a patient is available wherever they show up in the system. So they've really thought deeply about the care experience and how patients can be recognized and known everywhere in the system and how they can get the care that's most appropriate to their needs. They've also done, you might ask, okay, well, how does this translate into cost? And this graph will show you between 2001 and 2011 how Bellin's cost per capita compared to the average in their region. And when they started this work in the early 2000s, they were more expensive. Their employees were costing them more than the typical organization was paying for the cost of health care for their employees. They have substantially reduced that over time, and they're now greatly below the level of average cost for their region. And they figure over this period of time, they, as an employer, have saved $15 million in health care without harming anyone, while simultaneously improving the health and the health care experience of their employees. So this is the story that they now bring to the employers in their area to offer them services that will be competitive and very attractive. The second area I'll touch on briefly is that of children. So the first example, employees, it's very easy to see the business argument for this. Children is a bit more visionary undertaking. And what they have done to work with children is they are doing work in the public school system something called Planet Thrive, which is a way to engage elementary school children in building good health habits. So they do exercise classes in the schools. They help the children understand healthier eating habits. And what's happening is that the children are bringing these new learnings back to their families. The children are also, interestingly, doing better in school. Their academic achievement has improved. And right now, this is an area of investment for Bellin. They see this as part of their long-term strategy, but it's not yet formulated as a business case. It is, right now, they see it as a contribution to their community. And this is their vision statement. So if you are familiar with the kind of vision statements that often show up in the annual reports of healthcare organizations, they're often things like, we'll provide the safest care, the most patient-centered care, we'll be good citizens in our community. This is typically language like that. Their vision statement is quite different. Their vision is that the people in their region will be the healthiest in the nation. It says nothing about the health system itself. So that's where this innovative system is going, starting on the basis of being a good improver of their own operations and now pursuing the triple aim. So what they did in terms of leadership, they're a very business-oriented organization. They have competitors in their region, and their intention is to be able to show that they can deliver better value for lower cost while improving the health for all the segments in their population. They started at home. They started with their own employees as a way to learn. And that's a strategy that I would say has a great deal of potential. Many of our best sites have started exactly there. They're starting to do some experimentation with other segments where there may not yet be a business case to be made, but they're learning their way through that. And they're beginning to pursue what is being spoken of in the United States as more accountable business models, where the rewards for doing better at lower cost can be shared by the organization providing the care. Okay, how are we doing on time? I know we started a little bit late. Are we okay? Okay, so I'm going to, now we're going to go across the ocean to the Bolton Primary Care Trust in the United Kingdom. This is a structure that's a little bit in flux, but basically these are regional organizations that manage the budget for healthcare for an entire region. Bolton is in the northwest of England, which is a fairly economically stressed area. They have high rates of unemployment. They have a great deal of economic and cultural diversity there. So it's a part of the country that has some particular challenges. They serve about 261,000 people, and as a whole, the whole region has a shorter life expectancy than the country as a whole. And within their own borough, within their own territory, they have a great diversity and disparity in results, and I'll show you a map of this in a moment. The biggest contributors to death in this region are heart disease and stroke and cancer. And this is a map of the region, and it shows the rates of mortality for circulatory disease, so cardiovascular disease for the most part. And you'll see the very darkest regions are the regions where mortality is the highest. And there's a tremendous disparity from one part of the region to the other. In fact, the difference between the poorest or least healthy parts of the region and the highest, most healthy is about 15 years in life expectancy. So where they started was to reduce health inequalities, to start to close that gap between the most healthy and the least healthy parts of their region. And their design was to work in partnership with public health, the local authority, which is the local civic government, and primary care to improve health experience and well-being. Their strategy was to assess for risk 100% of all of their residents over the age of 45 and apply good primary and secondary prevention strategies. Some of this, much of it, was detecting undiagnosed cardiac risk factors and making sure that people got properly prescribed with appropriate medications. They also worked on smoking cessation. They worked on diet and exercise and general lifestyle modifications. They started, the little graph on the top they started in the neighborhood called Farnworth, and Farnworth is the poorest and least healthy district within their region. And they had a very systematic strategy for screening everyone. They worked with primary care doctors. They also went to the community, to sporting events and schools and places of employment and grocery stores and churches. Wherever they could find people to screen, that's where they went. And then the lower box shows you that they rapidly expanded it to their entire service area. So they didn't wait very long before they scaled it up. And they've started to see results. Before they started this work, on average, the life expectancy in their region was 2.3 years shorter. So their residents were dying, on average, 2.3 years younger than the country as a whole. And since they've been doing this work, that gap has shrunk to under 2 years. So they've made quite a distinct difference there. Within their own territory, the difference between the most healthy and the least healthy areas was a 15-year gap in life expectancy. So the difference between living to 60 and living to 75. And that gap, too, has begun to shrink. And this will show you how they're tracking their progress. So this will show you over time, starting in 2008, just before this work began, up to almost the present day. This is the first quarter of the current fiscal year. And this shows the admissions for heart attack, for myocardial infarction. And they are really starting to bring that down, mainly as a function of getting undiagnosed risk diagnosed and properly treated. In addition, their mortality rate is also beginning to drop. Again, a little bit more slowly than the heart attack rate, but they're starting to close that gap in a very systematic way. So this, for us, is a very inspiring story of looking at an entire population, looking at an entire region, choosing an issue that has great salience for a segment of the population, and really going big. So what they did was they set a very bold aim for the population. They harnessed not just the health system drove this, but the public health system and local government participated. They started small in the most deprived area and rapidly spread it across the region. And one of the things that was very successful was involving the community and involving local media. So there were billboards and television features and radio interviews. They really went all out to reach the community. So here we are, reflecting on this challenge of thinking and acting in new ways, taking the skills that we've built over time, taking the things that we know within the healthcare system about understanding and improving and maintaining better quality. And here's our old friend, our framework for the leadership for improvement, with some reflections on what else. So if this is the classic view, this is what we've been working with for quite some time within health systems. Where are we starting to expand this? And where are the edges of this that we may need to pursue in order to look at the triple aim for whole populations? So one of the things that is required to accomplish this work is to have some capacity for integration. Someone or some entity or some team or a coalition that can bring together the separated parts of the system, establish common purpose, and be a catalyst for intentional testing and learning and measurement. There are a number of ways that this can be accomplished. It doesn't necessarily mean that organizations have to merge, but things like informal working committees can be a possible mode of governance, finding ways to bring committees together within existing organizations, working in alliance, or in some cases we've actually had groups in the United States come together and put a formal structure together around a regional coalition that might involve health systems leadership, insurance companies, employers, civic organizations. That is beginning to happen. So we're really still in the early stages of our learning. So where are we going next? We predict that the United States and many other countries will continue to pursue the triple aim. It's a very challenging vision, but for us, a very catalytic vision. We've learned a lot, but there's a lot more to learn, particularly to address the challenge of achieving results at scale. To go from small test populations to an entire region or an entire system is no small challenge. So our journey at I.H.I. will continue starting in September with a new triple aim improvement community, and if that might be of interest to you, we'd love to let you know more. There certainly is more information on our website, and I put a little picture up there of a tool that we just built within the last couple of weeks that allows you to assess your own readiness, your organization's readiness to pursue the triple aim. We don't yet have this translated into Spanish, but I think we could manage that. If you tell us we should do it, then we will. And with that, I want to thank you so much for your attention and your warm welcome. Thank you very much.